Welcome everyone to the Top 20 Studies of 2022. I'm Dr. Jeff Donovan. I'm a dermatologist specializing in the area of hair loss. This is an annual event we hold every year in December, which celebrates the top hair research studies of the year gone by. And today I'd like to review with you 20 wonderful studies from the 2022 calendar year, which have really changed what we do in the clinic and changed how we think about hair loss. This will be uploaded to our Donovan Medical YouTube channel at a later date, and the recording will also be on the Evidence-Based Hair podcast, wherever you receive your podcasts. There will be a question and answer session at the end of today's session. You can enter any questions you have in the Q&A box, and I will review them at the end, and we will begin. I'd like to review with you today 9 studies in the area of androgenetic hair loss, 2 in the area of alopecia areata, 3 in the area of telogen effluvium and hair shedding, 4 in scarring alopecia, and 2 in other categories. But we'll begin first with studies in androgenetic hair loss. Androgenetic hair loss is also referred to as male balding and female pattern hair loss. This is a common type of hair loss affecting 30 to 40% of women by the age of 50 and 60 or 70% of men by the age of 60. And it's a type of hair loss which causes thinning in certain patterns. In women, it causes thinning in the center of the scalp, and in males, it causes thinning in the temples and the crown and then in the mid-scalp. A very nice study by Q and colleagues from February this year looked at the relationship between androgenetic hair loss and metabolic syndrome. So what is metabolic syndrome? Metabolic syndrome refers to this group of abnormalities that increase a person's risk for cardiovascular disease. And so metabolic syndrome comprises issues like high blood sugars, high cholesterol, high blood pressure, and obesity. And those 4 things comprise metabolic syndrome. And we know that metabolic syndrome increases the risk of heart disease, heart attacks, stroke, atherosclerosis. And there's been good data accumulating over the past many decades suggesting that patients with androgenetic hair loss have an increased risk for metabolic syndrome and an increased risk for heart disease. This data is not new. A landmark study in 1972 by Cotton and colleagues showed that one of the most important factors predicting heart disease in males was diastolic blood pressure. But what factor was also on that list? Hair loss. Hair loss in males. And so we've realized for some time that hair loss is associated with heart disease. That's 1972, so that's 50 years ago. And so the question we're asking now is, are patients with androgenetic hair loss at risk for developing metabolic syndrome? Well, a very nice meta-analysis or summary of the literature in 2014 showed that indeed patients with androgenetic hair loss have an increased risk for metabolic syndrome. And Wu and colleagues suggested the risk was 2.7-fold. Caro Cheng and colleagues in 2019 showed that the risk was about 2.59-fold. And now we have this very nice meta-analysis by Q and colleagues, 2022, showing an increased risk of metabolic syndrome of 3.46 in patients with androgenetic hair loss. So this was a systematic review and meta-analysis looking at the prevalence of metabolic syndrome in patients with androgenetic hair loss compared to controls. The authors reviewed 19 articles that met their inclusion criteria, including 1,342 patients with androgenetic hair loss and 1,189 controls. And so as I mentioned, their conclusion was that the increased risk of metabolic syndrome in patients with androgenetic hair loss was about 3.46-fold. But what was so interesting about this study is that when the data was looked at according to males and females, some very interesting findings came out. And that was specifically that females have a much greater increased risk of metabolic syndrome if they have androgenetic hair loss, and the risk was 7.34 in females compared to 3.08 in males. So there's a much closer association between metabolic syndrome and androgenetic hair loss in females. When the data was looked at in terms of early onset male balding versus typical onset male balding, the data showed that individuals with early onset androgenetic hair loss, these are our patients with hair loss in the teens and early 20s, that early onset male balding is associated with a greater increased risk of metabolic syndrome. So the conclusions here are that androgenetic hair loss is indeed associated with this increased risk of metabolic syndrome, this increased risk of high blood sugar, high cholesterol, high blood pressure, and central obesity. And we know that these increase the risk for cardiovascular disease. So I think this study is so important. It's been 50 years now since we first appreciated this important relationship between hair loss and heart disease. And very rarely do we bring up the topic of metabolic syndrome with our patients with androgenetic hair loss. But I think that we clearly should. I think the data is pretty clear in these 3 meta-analyses that patients with androgenetic hair loss, whether male or female, have this increased risk of heart disease, high blood sugar, high blood pressure, high cholesterol, central obesity. And I certainly think that this is a really important subject for our hair loss medicine field to really look at in greater depth. And perhaps we do need screening guidelines for patients with androgenetic hair loss. Perhaps we do need to be talking about blood pressure in a hair loss appointment. Perhaps we do need to be talking about obesity, high cholesterol, high blood sugar. Perhaps we do need to be encouraging patients to exercise, eat healthy. Of course, there's only so much we can do during a typical appointment, given time constraints. But I think this subject area has gone largely ignored. And it has been 50 years since this relationship has been identified. And I think this study reminds us that there is a striking relationship between androgenetic hair loss and metabolic syndrome that really can't be ignored anymore. And I think it's time for our field to look at this in greater depth and propose some guidelines for hair loss practitioners. We move on now to a very nice study looking at Nailfold capillary changes in patients with androgenetic hair loss. In our nail folds, we have blood vessels that can be easily identified with various magnifying devices. And this particular study showed that the Nailfold blood vessels are altered in patients with androgenetic hair loss. And so this study builds upon other studies, including the one I just reviewed, showing that males and females with androgenetic hair loss are at increased risk for cardiovascular disease. And we know that in the course of androgenetic hair loss, blood vessels are altered. A very nice study from this year showed that TGF-beta causes the delicate dermal papilla blood vessels in hair follicles to disappear, or as the authors stated in the JAAD article by Deng and colleagues, TGF-beta causes these dermal papilla blood vessels to vanish. And so there's this alteration in blood vessels in androgenetic hair loss, and the authors of that article propose that this is very relevant to androgenetic hair loss. These changes in blood vessels are very relevant to androgenetic hair loss. And so one of the ways to further identify what's happening in blood vessels and in the microcirculation is to examine the delicate nail fold capillaries in our fingers. There are several ways we can easily look at blood vessels in the human body. One is in the back of the eye, and so eye doctors and ophthalmologists are extremely skilled at seeing what's happening to blood vessels within seconds. But we can also see what's happening to blood vessels within seconds by looking at the nail fold capillaries in our fingers. And so you're well aware of the structure of the finger. We have the nail at the end and we have the finger, but what you may not be aware of is that we have these hairpin-like delicate blood vessels in the tips of the fingers just before the nail, and you can use a magnifying device called a dermatoscope to look at these blood vessels more readily. And dermatologists, rheumatologists frequently look at these blood vessels to identify certain types of autoimmune diseases, connective tissue diseases. We don't typically look at them in patients with androgenetic hair loss, but this study by Cao and colleagues reminds us that perhaps it's relevant for us to be looking at these blood vessels. So let's take a look at this really interesting study. These are the nailfold capillaries at the end of the finger. You can see the nail and the skin of the finger join up, and that is where these capillaries are found. They're shaped like hairpin type structures, and they're very regular. 1, 2, 3, 4, 5, 6. They're all lined up along the nail fold. So the authors of this study set out to investigate whether there are alterations in the nail fold capillaries in patients with androgenetic hair loss compared to controls. And in addition to examining the type of abnormality, they proposed a quantitative rating scale to score the abnormalities. A score of 0 meant there were no changes. A score of 1 meant there was less than 33% capillary alterations or reduction. A score of 2 meant 33 to 66%, and a score of 3 meant there was more than 66% capillary alteration or reduction. So what was the key conclusion of this study? Well, the key conclusion is that the nail fold capillaries, these delicate little blood vessel structures, are altered in patients with androgenetic hair loss. There's a total of 78 men in this study diagnosed with androgenetic hair loss, and their capillary findings, their capillaroscopy, was compared to 78 age and sex-matched controls. There was a number of different blood vessel structures which were identified, in addition to the typical hairpin structure. But what type of structures were more common in patients with androgenetic hair loss? What type of blood vessel findings were more common in the 78 men with androgenetic hair loss compared to controls? Well, there was 5. Avascular appearing capillaries, bushy capillaries, bizarre, dilated, and disorganized. Those were the 5 blood vessel structures which were more common in patients with androgenetic hair loss. So let's take a look at some very nice images that the authors supplied. They first remind us what the normal hairpin capillaries look like. Bushy capillaries were more common in androgenetic hair loss, and these are capillaries with many small branching limbs. Bizarre capillaries were increased in patients with androgenetic hair loss. These are capillaries with abnormal morphology. Dilated capillaries were more common as well. These are capillaries with a diameter of more than 20 micrometers. Disorganized capillaries are those with a complete distortion. And avascular areas are those areas with 2 or more successive areas lacking a capillary. And in the normal nail fold capillary, these blood vessels are lined up 1, 2, 3, 4, 5 in a very regular manner. And when they're missing, those are known as avascular areas. And so those were the 5 findings that were increased in patients with androgenetic hair loss. The androgenetic group also had a significantly higher frequency of nail fold capillary scores of 2 or more compared to the control group. And this reflects that a large proportion of the capillary network was affected in patients with androgenetic hair loss compared to controls. And so all in all, the authors proposed that capillary abnormalities are much more common in androgenetic hair loss compared to controls. And what they propose is that there may be widespread microcirculation injury in androgenetic hair loss. Not only is androgenetic hair loss a hair thinning condition, but it is a condition associated with widespread microcirculation injury. We can even identify this microcirculation injury in the nail fold capillaries. And more research is needed to understand the significance of these changes and whether any of these changes can predict certain metabolic or cardiovascular sequelae. In other words, if one identifies disorganized capillaries, does that mean that a patient is more likely to develop metabolic syndrome? If a patient has avascular areas, is that more predictive of the development of some coronary artery type diagnosis? We don't know. But I think this study is really important because it identifies these 5 changes: avascular areas, bushy, bizarre, dilated capillaries, and disorganized capillaries. And it fuels further research to understand what is the significance of this. And I really like this study because it reminds us that not only are we a field of hair loss, but we are a field of hair loss medicine, and we need to go beyond the hair follicle as practitioners in our specialty. That patients with androgenetic hair loss, for example, are at risk for metabolic syndrome. They are at risk for heart disease. And we will come back to this theme many times this evening, but I think that's so important. If we don't work to draw that connection, then we will really do our patients a disservice, because it's up to us as hair loss practitioners to help make those connections. We may not be the ones that treat high blood pressure, high sugar, diabetes. We may not be the ones that treat the systemic issues, but we can be the ones that refer patients to those specialties. We can be the ones that help put the ball in motion. We can be the one that discusses with patients that I would like to test your cholesterol, I would like to test your blood sugars, I would like to do these tests because research has taught us that there's this connection. So we are a field of hair loss medicine, and all these systemic associations are so important. If there are blood vessel changes in the fingertips, these delicate capillaries in patients with androgenetic hair loss, it is relevant, and it's important for us to know about this. We move on now to study 3 and 4, looking at the good cardiovascular safety of low-dose oral minoxidil. A very nice study by Sanabria and colleagues, followed by a very nice study by Jimenez-Caji and colleagues, looking at what happens to blood pressure, heart rate in patients receiving low-dose oral minoxidil. First, we'll begin by Sanabria's study, published in the Journal of the American Academy of Dermatology in May. Oral minoxidil is incredibly popular. If you look at Google Trends from 2017 to 2022, you can see that people are punching in the word oral minoxidil on the internet at increasing rates. And an article in the New York Times in the summer of 2022 heightened the awareness in many areas of the world, especially in North America, about oral minoxidil. And so the interest is quite great in oral minoxidil. Oral minoxidil was used in the 1970s and 80s to treat blood pressure at 10, 20, 30, 40, 50 milligrams. Those were the typical doses. It was a challenging medication to use. It caused fluid retention around the heart, around the lungs. It caused increased heart rate. It caused dizziness, but it promoted hair growth. And so it was those observations which led to minoxidil being formulated as a topical product, and that ultimately led to its approval for hair growth. There's been a resurgence of interest over the last 5 years in the use of low-dose oral minoxidil, but there have been several investigators over the last 10 and 15 years which have been studying this very carefully, including Dr. Rod Sinclair in Australia. And so the question that arises now is, if we're going to be using oral minoxidil at these low doses to try to get hair growing, is it safe? And what are the cardiovascular side effects? Do we get an increase in heart rate like we did in the 1970s and 80s when we were using 50 and 40 milligrams of minoxidil? Do we get these changes in blood pressure? After all, it's a blood pressure medication. So low-dose oral minoxidil is a dose of minoxidil 5 milligrams or less. Males with androgenetic hair loss are frequently treated with 2.5 to 5 milligrams. Females are typically treated with anywhere from 0.25 to 1.25. Some women are treated with 1.875, some with 2.5. But 1.25 and less are the more common doses in females. So Sanabria and colleagues wanted to ask the question, how much does low-dose oral minoxidil affect blood pressure? And so their study set out to determine how blood test results, blood pressure, heart rate change in males using oral minoxidil at 5 milligrams at baseline and then at week 24. And so it was a very nice study. Sanabria and colleagues connected patients with a Holter monitor to measure blood pressure, to measure heart rate. They did that at the beginning of the study and then again at week 24. And they measured heart rate and blood pressure over these 24-hour intervals. There was 34 males in the study. They were healthy males, aged 21 to 58. They did not have cardiovascular disease, and I think that's so important because these are studies of very healthy individuals. What were the findings? Well, the findings were pretty good. At 24 weeks, 20.6% of males reported they did have some headaches, 3% had vertigo, 3% had edema, but no patient had shortness of breath, no patient had palpitations. 60%, approximately 55.9%, had increased hair on the body or hypertrichosis. There were no changes in lab tests. No patient had hypotension or a blood pressure less than 90/60 during the 24-hour monitoring period. The mean systolic awake blood pressure dropped from 125 to 122, so by 3 millimeters of mercury. The diastolic blood pressure dropped from 76 to 74. Overall, there was no change in mean heart rate at week 24 compared to the beginning of the study. There was no statistically significant increase in ventricular or extrasystoles, either ventricular or supraventricular. So this is a very much needed study in our field. This data about safety of oral minoxidil was very much needed, and I congratulate Sanabria and colleagues for bringing this study to our field. Oral minoxidil in males appears to be quite well tolerated in this study. Systolic blood pressure and diastolic blood pressure change very little. A single 5 milligram pill changes systolic blood pressure by 3, diastolic blood pressure by 2 millimeters of mercury. Is that a lot? Not really. When you sleep at night, your blood pressure changes by about 10 millimeters of mercury. When you exercise during the day, your blood pressure increases by anywhere from 10 millimeters to even 60 millimeters of mercury. So we have wide swings in our blood pressure in a given day. It could be 70 millimeters of mercury changes for some people. So these changes of 3 millimeters of mercury systolic and 2 millimeters of mercury diastolic are quite small. An occasional patient in this study did have tachycardia. It was 3% in this study. And that was a short interval where the heart rate did go above 100. So from this study, I developed what I use in my clinic called the 3-2-1 rule. And it's a memory tool which allows me to counsel patients. And that is that systolic blood pressure changes by 3 millimeters of mercury, diastolic by 2, with 1 5 milligram pill of oral minoxidil in men. So that's a 3-2-1 rule. And that's been very helpful for me as I counsel patients. Many patients want to know, is my blood pressure going to change? Am I going to get dizzy? Am I going to pass out? And this study reminds us that the changes in systolic and diastolic blood pressure are very small. Most patients don't develop a change in heart rate. There can be occasional dizziness, lightheaded, tachycardia, so that's not impossible, but it's uncommon. So it's important to remember that this is a study of healthy males under age 60. It's not a study in women. It's not a study in those with cardiovascular disease. It's not a study in males over 60. And so we need those studies as well. But if you have a patient in front of you who's 35 years old, healthy, wants to start oral minoxidil, this study is applicable. If you have a patient in front of you who's 68 years old, has high blood pressure, this study does not apply. And so we need additional studies to further enhance our confidence in using oral minoxidil. But this is a wonderful study. Jimenez Cahi and colleagues published a similar type of study looking at the cardiovascular safety of oral minoxidil 5 milligrams. The question here is, does 5 milligrams of oral minoxidil affect blood pressure and heart rate in healthy males? Similar question as Sanabria and colleagues, isn't it? They studied 10 patients. Patients were assessed with ambulatory blood pressure monitoring every 20 minutes for a period of 24 hours on 2 different days. What were those 2 different days? Well, it wasn't time 0 in week 24, like Sanabria's study. It was time 0, and then right after they started the tablet. And so the following parameters were calculated every 2 hours before taking the tablet and after taking the tablet. Systolic blood pressure, diastolic blood pressure, and heart rate. Total of 10 patients were in the study, so we had 20 measurements before and after at each of these 2-hour time points. Mean age of patients was 27, ranging from 24 to 32. That's important to be aware of. This is not a study of 68-year-old males. It's not a study of 58-year-old males. It's not a study of 48-year-old males. Mean age 27.8, range 24 to 32. Important data. There was no statistically significant difference at baseline and at hour 24 in the mean diastolic blood pressure, systolic blood pressure, or heart rate. The only change was at 2 hours after taking the tablet. 2 hours after the 5 milligram dose, there was a non-significant change in systolic blood pressure, so it was not statistically significant, but there was a statistically significant decrease in diastolic blood pressure from 76.7 to 71.9. No significant changes in heart rate. So the differences only occurred at that 2-hour time point. There was no differences at hour 4, 8, 12, 24. None of the 10 patients had tachycardia or increased heart rate. But what was interesting in this study is that patients that had high blood pressure at the beginning were the ones that had the biggest drops in blood pressure with oral minoxidil. One patient had a bit of lightheadedness at 1 hour after taking the tablet, and it resolved spontaneously. So a very nice study. Him and his colleague performing a second very important oral minoxidil safety study, very similar to Sanabria's study. The conclusions here is that low-dose oral minoxidil appears to have minimal effects on blood pressure. There can be slight changes in the diastolic measurement at 2 hours, but then it returns to normal. Patients did not show evidence of tachycardia. The authors conclude here that patients with high blood pressure may be the individuals that experience a bit of a drop in blood pressure with low-dose oral minoxidil. And so certainly we'll need more studies about the safety of oral minoxidil in patients with high blood pressure. The basic tenet in the field is that if you have normal blood pressure, 120 over 80, 115 over 75, that oral minoxidil has minimal effects on blood pressure. If you have high blood pressure, low-dose oral minoxidil may lower it and has larger effects on blood pressure. So in healthy individuals, low-dose oral minoxidil has minimal effects on the cardiovascular system. Some patients could be lightheaded. That doesn't mean they need to abandon this treatment. It means one needs to monitor. Sometimes lightheadedness goes away, never returns again. It's a one-time thing. More likely in the beginning of the treatment plan than long-term. But it doesn't necessarily mean a patient needs to stop. So I thank these authors for these very nice studies looking at the cardiovascular safety of oral minoxidil. Sanabria's study and him and his colleague study is so important to our field to give us the confidence to use this medication in a safe manner. It's important to understand the limitations, the age group studied, but these 2 studies will fuel additional studies in this area. We move now to 3 very nice studies by my colleague Dr. Gupta, looking first at the relative efficacy of minoxidil, finasteride, and dutasteride in patients with androgenetic alopecia. So if you're asked to rank the efficacy of dutasteride, finasteride, topical minoxidil, oral minoxidil, how do you put them in order? Well, that's what Dr. Gupta set out to do. Which treatment wins first prize? Which wins second? Which wins third? So the authors examined the relative efficacy of any dose and administration route of minoxidil, dutasteride, finasteride. They performed a systematic review and meta-analysis of all the studies published in the literature. The key endpoints they were interested in looking at is the change in total and terminal hair counts at week 24 and 48. They found a lot of good data for week 24, limited data for week 48, and we'll come back to that in a minute. And they pulled from the literature studies that looked at minoxidil, dutasteride, finasteride as monotherapy. So there was 23 studies that they found. 11 pertained to 2% minoxidil, 8 pertained to 1 milligram of finasteride. So those were the majority of the studies retrieved. 3 were with dutasteride, 2 were with 5% minoxidil, 1 was with oral minoxidil, 1 was with 0.25 milligrams of oral minoxidil, and 2 were with topical finasteride. What was the conclusion? Conclusion is that dutasteride, 0.5 milligrams, is the winner. Not surprising. We know that in the year 2022 that dutasteride is the most effective treatment for androgenetic hair loss. And it's pretty difficult with the data we have right now to refute that. Gupta's study suggests that the second place winner is oral finasteride 5 milligrams, not 1, but 5. And the third place winner is oral minoxidil 5 milligrams. A very nice study, some surprises. Many patients of mine in the past have said, I think I do better with 5 milligrams of oral finasteride than 1. And my feeling has always been, but the literature tells us that you should be the same on 5 milligrams as 1 milligram. No, doc, I think I'm doing much better on 5 milligrams. This study suggests that indeed those patients are right. And I found that very interesting. I think there's data here that supports that for some patients, 5 milligrams will be superior to 1 milligram. What is also surprising is that oral minoxidil 5 milligrams finds a place at the top of the list as the most effective treatments for androgenetic hair loss, right up there with dutasteride and oral finasteride. I think that's really, really important data. And so the rank order is oral dutasteride, oral finasteride 5, oral minoxidil 5, oral finasteride 1, topical minoxidil 5%, topical minoxidil 2%. Dr. Gupta reminds us in this study that the overall quality of evidence is low. These studies have significant limitations. There's a lot of data at week 24, not a lot of data at week 48. Investigators like to do studies and stop them at week 24. That's 6 months. Going to 48 weeks, almost a year, that's expensive. That takes time. That takes resources. So a lot of studies stop at week 24, so we don't have a lot of great data at week 48, and that's a limitation. Most of these studies are with finasteride 1 milligram and topical minoxidil. Very limited studies with oral minoxidil, dutasteride, and again, limited studies at week 48. The data doesn't apply to females. The data doesn't apply to young patients. The data doesn't apply to old patients. So if a 15-year-old male is in the clinic and the patient or the parent says, what's the most effective treatment for androgenetic hair loss? You cannot pull up the Gupta meta-analysis and say, I've got a wonderful study for you which suggests that oral dutasteride is the most effective treatment, followed by oral finasteride 5, followed by oral minoxidil 5. That data does not apply to this age group, so we can't make those conclusions. It's tempting, but you can't. And so we need to understand these limitations, and this data, again, has limitations in the quality of evidence, but it's a really wonderful study, carefully designed, carefully conducted, and really draws some important conclusions that give some guidance in terms of how we rank the hierarchy of treatments. Dr. Gupta also performed a very nice study looking at platelet-rich plasma and how we should be performing platelet-rich plasma procedures. Who does it work best in? Who does it work less well in? So PRP is a recognized treatment for androgenetic hair loss. It's not FDA approved. The FDA doesn't want to regulate it because it is a product that comes from the person's own blood. And so the FDA has said in that case that it really doesn't want to be involved in the regulation. And on account of that, there are many, many protocols. There are many machines. There are many ways of taking the blood. There are many ways of activating the blood. There are many ways of spinning the blood. There are many things that can be added. And there are easily 500 different protocols. If you were to add them all up, there's probably 2,000 or 3,000 different protocols. And so it's really not clear how best to perform PRP. So what protocol is best? Well, the authors set out to perform a study to look at what treatment protocols might be best and which ones might not be quite as good. So they performed a multivariable meta-regression and network meta-analysis, a method of looking at the data and drawing conclusions from all of the data as to what might work best. 25 trials met their eligibility criteria. There was 10 unique PRP regimens that were ultimately used in their calculations. What are the best protocols? Well, patients that have more PRP sessions or come in the clinic more often seem to do better than patients that come into the clinic less often. So if you have two patients in the waiting room and one says, in 2021, I came in twice for PRP. And the other patient says, I came in 8 times. The patient who came in 8 times probably will do better with their hair. Now, there's other factors as well, but that's the first variable that's so important from Dr. Gupta's study, that if you come in more often, you have more treatments, you probably have better results. If you activate the PRP at the end of the study, and PRP can be activated in many ways, including with calcium, it seems to work better than if you don't activate the PRP. If you use a centrifuge, which allows for a double centrifugation method, it probably works better. PRP seems to work better in patients that are younger than older, and patients that are female than patients that are male. Does PRP work in male patients? Of course. Does PRP work in someone 65 compared to 35? Of course. But this data suggests that it works slightly better in patients that are female, patients that are younger, and if the PRP is activated and processed with a double centrifugation method. So a really nice study. Studies of PRP are generally quite small. Studies of PRP are generally very poorly designed. It's a major effort to pull data from the PRP literature and analyze it with some rigorous methodology. Studies in PRP are notoriously very poor. But this data gives us some insight into what type of parameters may be the most helpful. And I think this study will indeed fuel other studies. I don't think this study provides us with a guideline that moving forward in 2023, we should do PRP with this methodology, this methodology, this methodology because of Gupta et al. 2022. No, I don't think so. But it certainly is extremely helpful to get us a little closer to speaking about what type of protocols may be the best. There truly are hundreds and hundreds of different protocols. The way someone performs PRP up the street is different than the way they perform PRP down the street. And if someone says to me, I went up the street, I didn't get a good result, should I go down the street and do PRP? My feeling is, it's worth a shot. It probably won't work if you didn't get a result up the street, but we don't know if the people up the street activated the PRP the same way that the people down the street activated. We don't know what centrifuge the people up the street used compared to down the street. And so we desperately need a little bit more consensus in how we do PRP, and that's so important. And there are hundreds upon hundreds of different procedures to do PRP. And so it's unfortunate we use the term PRP because we really should be saying PRP method 87.47b, North America dash, Denver dash, West Denver dash, Clinic 47 dash. There's just so many protocols. Dr. Gupta and colleagues performed another very nice study looking at what happens when you increase the dose of oral minoxidil? Does it work better? And if it works better, do you get more side effects? Or does it just work better? So what happens when you increase the dose of oral minoxidil by 1 milligram? So Dr. Gupta set out to determine the safety and efficacy of oral minoxidil. They performed a systematic review of the literature and found 6 studies that were eligible for their analysis. So what happens when you increase the dose of oral minoxidil 1 milligram? Well, after 6 months of use, increasing the dose of low-dose oral minoxidil in patients with androgenetic hair loss is associated with an increase in hair diameter of 1.4 micrometers, an increase in hair density of 47 hairs per centimeter squared, and an increase in terminal hair density of 9.1 hairs per centimeter squared. After 6 months of use, in patients with androgenetic hair loss, increasing the dose of oral minoxidil by 1 milligram increases the risk of hypertrichosis by 17.9%, and it increases the risk of cardiovascular adverse events by 5%. Things like hypotension, edema, increased heart rate, palpitations, or an abnormal EKG. A really important study telling us that the risks and benefits of oral minoxidil are dose dependent. So when a patient comes into clinic and says, I've been doing really well on 2.5 milligrams of oral minoxidil, hair's coming back, I'm so pleased, don't have any side effects. What do you think, doc, if we increase it by 1 milligram? Well, we can now say to that patient, you will likely have an increase in hair density of X amount of hairs per centimeter squared, 47. You will have an increase in 9 hairs per centimeter squared that are terminal. But if we go up by 1 milligram, you have a 1 in 20 chance of cardiovascular effects, meaning you have a 1 in 20 chance of coming back and saying to me, I have palpitations, I have dizziness. And you have an 18% chance of coming back and saying, you know what, it's helping my scalp, but I've got more hair on my chest, on my body, on my back, on my arms, on my legs. And so if that's something that you don't like, then we have to weigh those risks and benefits. So a really important study which gives us some numbers, gives us some ability to improve the counseling we do to patients. And I think this study is immensely helpful. It's something that I think about almost daily when I'm counseling patients that are thinking about going up on oral minoxidil. A very nice study from New York by Clin and colleagues looked at whether adding topical minoxidil to someone about to start oral minoxidil really does anything. Study published in the Journal of Cosmetic Dermatology. So if you're planning to start oral minoxidil, are you wasting your time and money by starting topical minoxidil too? That's what Clin and colleagues set out to look at. A first-of-its-kind type study, a study with several limitations, but nevertheless an intriguing study which gets us thinking. A study which gets us thinking that perhaps if we're going to prescribe oral minoxidil, we should just leave topical minoxidil out of the plan. So the authors aim to compare the therapeutic outcomes of patients treated with oral minoxidil compared to patients treated with oral minoxidil and topical minoxidil. So we have two groups of patients, a low-dose oral minoxidil alone group and an oral minoxidil and topical minoxidil group. Small study, 117 patients. Patients had mostly androgenetic hair loss, but some had androgenetic hair loss and telogen effluvium, some had androgenetic hair loss and alopecia areata, but most had androgenetic hair loss, and I think that's what's important here to remember. Everyone was treated with low-dose oral minoxidil, but 60% of patients had low-dose oral minoxidil and topical minoxidil twice daily, the combo group. Oral minoxidil was prescribed in various doses. Most patients had 1.25 and 2.5 milligrams. A very small number had 0.625 milligrams, and very few patients at all were prescribed 5 milligrams. So here in North America, oral minoxidil comes as 2.5 milligram tablets, and so they can be broken in half or in a quarter, and that's why in North America, patients are frequently prescribed 0.625, which is a quarter, 1.25, which is a half, 1.875, which is 3/4, or 2.5, which is a full pill. In other parts of Europe, etc., the pills may come as 5 milligrams. Some parts of the world, they come as 10 milligrams. And so patients were assessed at 3 to 6 month intervals. Low-dose oral minoxidil and the low-dose oral minoxidil topical minoxidil combo group both had an increase in density and an increase in hair caliber. But the key point is that the increase in density and hair caliber were exactly the same. It was not that the combo group of oral minoxidil and bonus topical minoxidil worked better. Not at all. The groups performed very similarly. So there was no real added benefit of adding topical minoxidil in this small study of 117 patients. And so most patients using oral minoxidil would not be expected to get much more benefit from adding topical minoxidil to the plan. So if you're planning to start oral minoxidil, are you wasting your time and money by starting topical minoxidil too? The study suggests yes. I think this study needs replicating by other groups. I think this study needs further investigation, but I think it's extremely intriguing, and I congratulate Clin and colleagues for this wonderful study. I think it's so important for us to really understand this information. This is a small study. The authors included patients with many types of hair loss, so it wasn't just androgenetic hair loss, but most patients did have androgenetic hair loss, and so it certainly is suggestive, but it's challenging to tease apart differences when you have different types of hair loss. Males and females were included in this study. Could there be differences in males and females? There could be. And so it may be important to investigate these studies in males alone or females alone. And we don't know if patients using really small doses of oral minoxidil, like 0.25, are likely to benefit if you add topical minoxidil. Only 18% of patients in this study were on 0.625 milligrams, so low doses. And clearly, if you were to start a patient on 0.00000000001 milligrams of oral minoxidil, it's probably going to be beneficial to add topical minoxidil. That's just a hypothetical scenario, but clearly if you're on a low enough dose of oral minoxidil, then yes, it probably will benefit you to have topical minoxidil on board too. So what is the cutoff? We don't know. Is adding topical minoxidil in a female patient using 0.25 milligrams of oral minoxidil helpful? Well, we don't know. This study studied mainly 1.25 and 2.5 milligram users. Some were 0.625, but not many. So if you're on low doses of oral minoxidil, should you be on topical minoxidil too to get extra kick? Maybe. This study didn't address that, but it's an intriguing study. It sets the stage for further good studies, and I congratulate these authors. This is really, really important. What this study does not suggest in any way, shape, or form is that if a patient comes into clinic and they're on oral minoxidil and they're on topical minoxidil, and they say to you, I just heard this study that I'm wasting my time and money by using this topical minoxidil. I don't like applying it. It's messy, it's goopy, it changes my hair. I don't have time. I don't like topical minoxidil. I want to stop it. I've heard that it makes no difference. This is not a study which addresses whether stopping topical minoxidil in someone on long-term combo therapy is a good idea or not. This is a study, the Clin and colleagues study, which addresses what happens from starting. If you're about to start oral minoxidil, should you add topical minoxidil at the same time on day one when your plan is underway? That's what this study is about. And so if a patient's on long-term oral minoxidil and topical minoxidil therapy, I would be pretty leery about stopping their topical minoxidil until we have good data. It absolutely is possible that patient could lose hair on account of that. And so more studies are needed, but I congratulate the authors. This is a wonderful study which really gets us thinking about how we should be using topical and oral minoxidil together. And finally, study number 9 in the category of androgenetic hair loss is a study of female pattern hair loss looking at microneedling compared to oral spironolactone. in patients using Minoxidil. So microneedling is very popular. It involves the use of small needles, 0.2, 0.5, 1 millimeter, 1.5 millimeters in size, and the scalp is purposely injured to create a small wound. And the hope is that that wound stimulates hair follicle stem cells and stimulates pathways that lead to hair growth. It's not fully understood why microneedling would help hair. It's thought that perhaps it promotes activation of the Wnt beta-catenin signaling pathway, and that stimulates dermal papilla stem cells. Perhaps it stimulates angiogenesis. Perhaps if you put minoxidil on the scalp and you do microneedling, perhaps it allows the minoxidil to get in the scalp easier by creating these little microchannels. And perhaps microneedling increases minoxidil sulfotransferase enzymes, which then converts minoxidil into the active form more readily. But the mechanisms are still debated. Why does this microneedling technique work? Does it work in everyone? Are there patients by which it actually worsens the whole situation? Probably. We need more research. But if you're going to speak about microneedling, you need to be pretty well versed about a fundamental landmark study by Durat and colleagues in the International Journal of Trichology in 2013. Durat and colleagues performed a randomized study looking at the benefits of minoxidil compared to minoxidil and microneedling. 44 patients in the minoxidil-only group, 50 patients in the minoxidil and microneedling group. So patients in the microneedling group were microneedling weekly with a 1.5 millimeter microneedle. What worked best? Well, the minoxidil microneedling protocol worked better. Patients thought it was significantly better. Investigators looking at pictures thought that the combo group did much better, had better results, and hair growth was much better in the combo group. So Durat and colleagues is a really important study to know about, and was indeed a study that launched studies like the one I'm about to mention to you today. So Liang and colleagues set out to perform a similar study with a few slight differences. So it set out to determine whether adding microneedling to a topical minoxidil plan worked better than oral spironolactone and topical minoxidil, and whether any of this worked better than just doing topical minoxidil alone. And so they performed a prospective, single-center, randomized trial of 120 premenopausal women with female pattern hair loss. There was 3 groups: minoxidil 5% once daily, minoxidil 5% once daily with microneedling every 2 weeks with a 0.7 to 1 millimeter microneedle, compared to minoxidil 5% once daily with oral spironolactone, 80 to 100 milligrams. Oral spironolactone is an anti-androgen used for many, many years in the treatment of androgenetic hair loss. It's used off-label for women. So the authors looked at changes in hair density, hair diameter, physician global assessment. What did physicians think about the final results? Patient evaluation. What did patients think about the results? And side effects. So the criteria for participating in this trial was you had to be between 18 and 45 years of age, female, have normal hormone levels, and be a Sinclair class 2 or 3, not 4 and not 5. So early moderate androgenetic hair loss. How was microneedling done? Well, it was done every 2 weeks. Patients washed their hair before treatment. Alcohol was used to clean the site 3 times. 1 milliliter of minoxidil was applied, and then microneedling was done with this 0.7 to 1 millimeter microneedle. Patients were advised not to wash their hair for 8 hours and not to use additional minoxidil for 24 hours. So what were the results? 115 patients in the study started with 120, but 5 dropped out. 38 in the minoxidil-only group, 37 in the minoxidil spiro group, and 40 in the minoxidil microneedling group. Who was the winner? Minoxidil microneedling. the Minoxidil protocol with microneedling every 2 weeks with that 0.7 to 1 millimeter microneedle was more effective than Minoxidil spironolactone. That was the second place, and both of those were better than Minoxidil alone. There's an increase in hair density the most in the Minoxidil microneedling group. Hair shaft diameter increased in all groups, and there was no significant difference. The diameter increased by about 15 micrometers. When investigators were asked to look at photos at week 24, in the Minoxidil-only group, an improvement was noted in 55% of patients. An improvement was noted in about 86% of patients in the Minoxidil spiral group, and in 95% of patients in the Minoxidil microneedling group. So what were the side effects? Well, scalp itching was the most common side effect. The Minoxidil spironolactone group reported the most adverse events. Of the 40 patients in that group, 15 had irregular periods, hyperkalemia in one patient, edema of the limbs in one patient. There was one infection in the microneedling group. It was short-term and didn't cause the patient to stop treatment. So a really nice study showing the superiority of microneedling and Minoxidil compared to Minoxidil spironolactone. Side effects were less in the Minoxidil microneedling group compared to the Minoxidil spiral group. Would a combination of all three treatments work even better? Would a combination of microneedling with oral spironolactone with microneedling Minoxidil work the best? We don't know. But a really intriguing study suggesting superiority of microneedling over spironolactone, very slightly, but much better tolerated in females with androgenetic hair loss. So very, very nice study, which builds on the DURAT study of 2013 and fuels further study and investigation in the role of microneedling. Microneedling is a really important topic. Patients are using microneedling, using home microneedling, office microneedling, 0.6 millimeter microneedles, 1.5, doing it every 4 days, every 10 days, every 2 weeks. There's extremely large number of protocols, and we really need more research to understand how this can be used best. So we move from androgenetic hair loss to studies of Alopecia Areata. Alopecia Areata is an autoimmune disease which affects between 1% and 2% of individuals in their lifetime. It can cause a patch of hair loss, which then grows back. It can cause hair loss that extends the entire scalp, which is called alopecia totalis, or the scalp and eyebrows, eyelashes, body hair, and that's called alopecia universalis. And the treatment depends on the degree of hair loss. And so when someone says to me, how do you treat alopecia areata? My question back to that individual is, what is the stage of alopecia areata? How much hair loss does the patient have? If a patient has a single patch of hair loss, I may treat it with topical steroids, steroid injections, and Minoxidil. If a patient has alopecia universalis, topical steroids, steroid injections, and Minoxidil is not going to help, and we need systemic treatments. So Dr. King and colleagues published a very nice study in the New England Journal looking at the role of baricitinib in advanced alopecia areata. These were the findings from the BRAVE AA1 and BRAVE AA2 trials, which were the trials which ultimately led to the FDA approval of baricitinib for alopecia areata on June 13th, 2022. A really monumentous day in the hair loss field where baricitinib was approved for alopecia areata. Up until June 13th, we did not have any formally approved treatments for alopecia areata. We had dozens upon dozens of off-label treatments, but no formally FDA-approved treatments. And so Dr. King and colleagues performed the BRAVE AA1 and AA2 trials, which allowed baricitinib to be approved. So baricitinib is a JAK inhibitor. It's a JAK1, JAK2 inhibitor. Tofacitinib, which you may be familiar with, is a JAK1, JAK3 inhibitor. And baricitinib was approved June 13th for advanced alopecia areata. And it's the data that I'm about to share with you now that convinced the FDA that approval was a good idea. So the BRAVE AA1 and AA2 were randomized, placebo-controlled trials involving patients with severe alopecia areata with a SALT score of 50 or higher. Patients were randomized to receive either a placebo tablet or baricitinib, 2 milligrams, or baricitinib, 4 milligrams. And patients were randomized in a 3 to 2 to 2 design, meaning slightly more patients received baricitinib 4 milligrams than 2 milligram group or placebo group, but there were 3 groups that were studied. The primary outcome was what proportion of patients had a SALT score of 20 or less at week 36 at the approximately 9-month mark. There were a number of secondary outcomes. How did patients' eyebrows and eyelashes improve? How many patients achieved a SALT score of 10 or less? So there was other secondary outcomes, but the primary outcome was what proportion of patients had a SALT score of 20 or less. So what's a SALT score? A SALT score of 100 means no hair on the scalp. A SALT score of 0 means complete hair growth. And so a SALT score of 20 is the primary endpoint of the study. What percent of patients had this SALT score of 20 or less? So not complete hair growth, but what percent of patients had some pretty cosmetically important regrowth? They may still have had hair loss, but the SALT score of 20 was used as the cosmetically significant regrowth density. So the BRAVE-AA1 enrolled a total of 598 patients at the end. There was more enrolled initially, but about 10% were unable to complete the trial. The BRAVE-AA2 had about 490 patients in the final group. What's so important about the BRAVE-AA1 and AA2 studies is that a significant number of patients had alopecia universalis, so complete hair loss, very high number, which is really important. It is very difficult to promote hair growth in alopecia universalis, and so if a treatment promotes hair growth in alopecia universalis, it's really important. Most patients had a duration of hair loss of about 3.6 years in the BRAVE-AA1, 4.3 years in the BRAVE-AA2. 30 to 40% of patients had alopecia areata for more than 4 years. 60% approximately were white, 30 to 40% Asian, 7 to 10% were black. How well did baricitinib work? What percentage of patients achieved that SALT score of 20 or less? Was it 5%, 15%, 35%, half, 80%? Well, it was 35%. So just over a third of patients achieved a SALT score of 20 or less at that week 36 mark. In the 4 milligram group, the BRAVE-AA1 data showed that it was around 38.8% of patients achieved that, 35.9% in the BRAVE-AA2 group. In the placebo group, about 6% in the BRAVE-AA1 achieved a SALT score of 20 or less, and it was 3.3% in the BRAVE-AA2. And that's really important data. We need those good placebos in these studies. The placebo response in alopecia areata is not insignificant. But in total, about a third of patients had some very good results with 4 milligrams of baricitinib. And baricitinib, 4 milligrams worked better than 2 milligrams. What percent of patients achieved a SALT score of 10 or less? Even better hair growth. Well, it was about 25% achieved that density. Side effects were generally mild to moderate in most patients, but not all. The percent of patients that dropped out of the study, that 10%, was similar in the placebo group, similar in the 2 milligram, and similar in the 4 milligram group. There were some adverse events in both the BRAVE-AA1 and BRAVE-AA2 study. There was acne in about 6% of patients, respiratory and tract infections, headaches, urinary tract infections, increased cholesterol. About 25% had some increased cholesterol numbers compared to about 15% in the placebo, increased creatinine kinase. Herpes zoster or shingles occurred in about 0.5, 0.7% of patients, just a little bit higher than the placebo in the BRAVE-AA2 trial. So it wasn't a lot of patients, but a small number had shingles infections. Serious side effects, serious adverse events occurred in 2.1% with the 4 milligram dose, compared to 1.6% in the placebo group in the BRAVE-AA1. In the BRAVE-AA2 trial, 3.4% had serious adverse events with 4 milligrams compared to 1.9 in the placebo. And overall, baricitinib 4 milligrams was better than 2 milligrams, and 2 milligrams was better than placebo. And 1/3 of patients achieved good results. So really important study which led to the FDA approval of baricitinib. Baricitinib, along with other JAK inhibitors, come with this black box warning. And the FDA has said that right now, if you're going to manufacture a JAK inhibitor of similar kind, that we're going to attach this black box warning to the JAK inhibitors, and that is we need to remind patients about the possibility of serious infections, higher mortality or death, higher risk of cancer, higher risk of cardiovascular events, higher risk of blood clots. And these black box warnings come from studies of rheumatoid arthritis patients, and these are data from the oral surveillance trial, which looked at side effects in patients with rheumatoid arthritis 50 years of age and over who were receiving tofacitinib and methotrexate. And in that oral surveillance trial, the data suggested that patients may have an increased risk of infections, cancer, heart disease, blood clots. And so the FDA has said that we're going to put this warning on all the JAK inhibitors for now. A major effort in the next few years will be understanding whether this black box warning is really relevant to other groups outside of rheumatoid arthritis. And we're beginning to get some data that suggests that if you're using a JAK inhibitor for other disease states, like atopic dermatitis, like vitiligo, like alopecia areata, that this data may not apply in the same way as it does in rheumatoid arthritis. We're not sure completely, because studies are small. Follow-up is limited. The BRAVE AA1 and AA2 are just 36 weeks in length. But it may not be that the risks that we see in rheumatoid arthritis patients 50 years of age and over who are on tofacitinib and methotrexate have the same risk as a 22-year-old patient with alopecia areata who is on a JAK inhibitor like baricitinib. So we don't know. But for now, the FDA has said this warning needs to be placed on the product. And before a patient starts, they need to be counseled about the possibility of infections, cancer, cardiovascular, and blood clots. But we're not sure if truly these side effects apply to our patient population with alopecia areata. And so we'll be seeing a lot more data in the years to come, looking at whether these side effects are relevant to our hair loss specific populations. Another very nice study in the alopecia areata field was a study from Poland by Łaskiel Bernat and colleagues, Lydia Runika's group. A very nice study looking at the risk of endothelial dysfunction in patients with alopecia areata. A large body of data is accumulating suggesting that patients with alopecia areata are at increased risk for heart disease. And so Dr. Łaskiel Bernat and colleagues set out to look at whether patients with alopecia areata have blood vessel abnormalities, endothelial dysfunction that could explain an increased risk for heart disease. Now, before we dive into Łaskiel Bernat's study, let's take a look at a landmark 2020 study of alopecia areata. It was by Connick and colleagues from the Cleveland Clinic, titled Prevalence of Cardiac and Metabolic Diseases Among Patients with Alopecia Areata. That study, published in the Journal of the European Academy of Dermatology and Venereology, showed that there was an increased risk of high blood pressure, obesity, hyperlipidemia, metabolic syndrome, heart disease, stroke in patients with alopecia areata compared to controls. And so Łaskiel Bernat and colleagues set out to determine if the blood vessels are different in patients with alopecia areata. Is there dysfunction of the blood vessel lining called the endothelium in patients with alopecia areata? And these are healthy patients without cardiovascular disease. And so they enrolled 52 patients with alopecia areata, 38 female, 14 male, and compared the data to 34 matched controls, matched for age, sex, and body mass. So how do you measure endothelial dysfunction? How do you measure if the lining of the endothelium is working properly or not? Well, there's some very easy ways to do it. And one such device is called the EndoPat 2000 device, a device where you sit in a chair in an office, you have a blood pressure cuff hooked up to your arm, and you have a probe at the end of your finger. You inflate the cuff to shut off the blood supply temporarily, and then you let the blood rush into the finger, and you measure how quickly the blood rushes to the finger, the waveforms. You measure how the blood vessels respond. And from that, you can get measures of endothelial dysfunction very readily. This number pops up on a computer. You can get the reactive hyperemia index, RHI, and you can get a measure of arterial stiffness called the augmentation index. And so by calculating RHI, the reactive hyperemia index, the researchers showed that endothelial dysfunction, or an RHI number less than 1.67, was observed in 42% of patients with alopecia areata, compared to just 12% of controls, and this was statistically significant. There was no significant difference in the augmentation index. So to cardiologists, the RHI and the augmentation index are really important numbers. So if a patient comes in clinic, sits in a chair, has one of these devices, the blood pressure and the probe on the finger, and they get this measurement that pops up on the computer screen, you have an RHI of 1.44. It means that patient is at increased risk for heart disease. It's a predictor of cardiovascular disease, and it's a really important number to cardiologists. We don't think about it in the hair clinic. It's not something that we deal with, but it is quite easy to measure these numbers. And so the authors here show that these measures of endothelial dysfunction are different in patients with alopecia areata, that there is evidence that the blood vessels are abnormal in healthy patients without cardiovascular disease. I think this is a really important study. Again, we're moving away from thinking about hair diseases as isolated hair diseases of hair follicles. Of course, that's what we focus on in the clinic, but these hair loss issues have systemic implications. That patients with alopecia areata have an increased risk for heart disease. Patients with androgenetic hair loss have an increased risk for heart disease. We'll see in a minute that patients with lichen planopilaris have these risks as well. So what type of screening should we be doing in patients with alopecia areata? In a patient with alopecia areata, should we be measuring their baseline blood pressure? Should we be measuring their cholesterol? Should we be measuring their body mass index? Should we be looking at their diet? Should we be looking at their exercise protocols and how much they exercise? Should we be looking at stress in their life? Should we be taking family histories of heart disease, high blood pressure, high cholesterol? The answer is probably yes. But we're not there yet. We saw earlier that it was 50 years ago that we first identified a relationship between male balding and heart disease. And we don't talk about male balding and heart disease in a typical visit regarding male balding. And that was 50 years ago. And here we have this wonderful study by Dr. Westgill Burnett and colleagues reminding us of this important association that builds upon conic study in 2020. These are very important associations. And I think that we shouldn't wait another 50 years before we do something about it. I think we need to move forward with thinking about screening and thinking more carefully about these important associations. But I really like this study. Westgill Burnett, Dr. Rudnika's group really have highlighted this important association that alopecia areata is associated with endothelial dysfunction. And from the conic study, we know that androgenetic hair loss and alopecia areata are associated with metabolic dysfunction, and that increases the risk for heart disease. So we move now to studies in hair shedding. Studies in hair shedding pertaining to COVID-19 are the three studies I'd like to highlight today. Wonderful studies of 2022. Dr. Mueller Ramos and colleagues published a very nice study looking at the prevalence and associated factors in patients with COVID-19, looking at a very large study of almost 6,000 patients. So who exactly is getting hair loss? And what happens when you have COVID-19? What are the factors that are associated with hair loss? And so the authors set out to evaluate the prevalence of hair loss and what other concerns are present within 3 months of a COVID infection. They performed an electronic survey using text messaging, SMS messaging, to collect data. So a very nice study where patients received messages on their phone. Have you had COVID-19? If you've had COVID-19, can you fill out this survey? And if you didn't, can you pass it on to someone else? And if you did, can you pass it on to someone else? And that's how they accumulated almost 6,000 patients. So of the 5,891 patients, these were patients that were recruited during the alpha wave of the pandemic. Participants had variable degrees of illness. About 90% were treated at home with slightly more mild illness. 6.7% were treated in hospital and 3.9% were treated in the ICU. Hair loss was the most common symptom of COVID-19 in those 5,800 patients. Memory loss occurred, loss of attention, weakness, anxiety, headaches, depression occurred, but hair loss was number one. About 50% of patients had hair loss after COVID-19, and it was fairly equally divided between mild hair loss, moderate, and severe hair loss. What was interesting in the Mueller-Ramos study is that patients that were hospitalized were more likely to have severe hair loss. So in this study, there was a connection between severity of hair loss and severity of the COVID infection. Hair loss was associated with the disease length, how long COVID lasted, and whether you had fever, whether you had severe shortness of breath and muscle pains. In this study, 77% of patients had hair loss within the first 30 days, and 15% had hair loss 30 to 60 days out. Females were more affected than males, and females had a 5-fold increased risk of developing hair loss after COVID compared to males. What was particularly interesting in this Mueller-Ramos study is the development of hair symptoms in patients with COVID infection. Hair symptoms like pain and burning and discomfort and abnormal sensations is something that is referred to as trichodynia. And about a quarter of patients in this study had trichodynia. 10 to 12% had trichodynia during the COVID infection, and 11 to 13% had trichodynia after the infection resolved. Patients with late onset trichodynia were more likely to have severe disease and be hospitalized. I think this is really important. When COVID infections first started, a large number of patients would report hair loss, but a large number of patients would mention to me that they're experiencing scalp pain, burning. And there was uncertainty at that time. Is this burning and pain due to telogen effluvium, which sometimes gives these symptoms? Is it due to seborrheic dermatitis? Is it due to the development of some autoimmune issue in the scalp? And so this study highlighted just how common trichodynia is in patients with COVID-19, that upwards of a quarter of patients in the alpha wave were experiencing trichodynia. So a really important study which highlights that females are much more likely to be experiencing hair loss after COVID-19 than males, and it was 5-fold greater risk in this particular study. So a really important study in 2022 which really highlighted the factors associated with hair loss in patients with COVID infection. Miola and colleagues performed a very nice study as well, looking at early onset hair loss in patients with COVID-19. There are 2 patterns of hair loss after COVID-19 that I'd like to remind you about. Patients that have COVID-19 may or may not lose hair, but if they do lose hair, some may lose it within the first 2 to 4 weeks. That's called the early onset pattern. And some patients may lose it between 4 to 12 weeks. That's what we call late onset. The authors of this study, Miola and colleagues, set out to evaluate the clinical presentation of hospitalized patients with COVID-19, and they identified 203 patients. 11 of those had hair loss occurring within 30 days. That was 5.4%. And so they wanted to further understand what's going on in patients with early onset hair loss. So they performed trichoscopy, trichograms, and biopsies to better characterize what's going on with early hair loss. What's different about early hair loss compared to typical hair loss at month 2 or 3? So trichoscopy was pretty bland. It didn't really show much. There's no broken hairs, no anisotrichosis or variation in caliber, no yellow dots. There was just some empty follicles. Trichogram, or forceful plucking of hairs and examining those hairs, showed that 10% of hairs were dystrophic anagen hairs, or abnormally shaped anagen hairs. Biopsies showed mostly terminal anagen follicles. There was a slight increase in telogen follicles, but not more than 25%. Not what we would be expecting in a typical massive telogen effluvium. And there was no significant inflammation. And so the conclusion here is that early onset shedding is a dystrophic anagen effluvium. That patients who say, I had COVID 2 weeks ago and I'm shedding now, that patient probably has an anagen effluvium rather than a telogen effluvium. And so there are these two distinct mechanisms of hair loss in patients with COVID-19. So a really important study which changed how we think about hair shedding in patients affected by COVID-19. Mazzito and colleagues published a very nice study building upon this data further. They performed electron microscopy studies looking at what's happening to hairs in patients with early onset shedding. And they described a 25-year-old woman that was admitted to hospital with cough, fever, shortness of breath, and she had a PCR positive test for COVID-19. She was ill. She required oxygen. She was given corticosteroids, antipyretic drugs. She had a positive pull test for anagen hairs, suggesting again that she has this dystrophic anagen effluvium mechanism. She had a biopsy. It showed what biopsies of dystrophic anagen effluvium show in the setting of COVID-19, and that was mostly anagen hairs and no inflammation. But hairs were submitted for electron microscopy, and the electron microscopy data showed cytoplasmic vesicles with several viral structures in the anagen hair follicle. And this is evidence that the SARS-CoV-2 viral particles are infecting hair follicles. And so the mechanism of dystrophic anagen effluvium may involve the SARS-CoV-2 virus infecting hair follicles. And the authors propose that this early onset mechanism may be characterized by SARS-CoV-2 replication in the outer root sheath, a high rate of dystrophic anagen hairs on a trichogram, more than 10%, biopsies which show mostly anagen hairs with no inflammation, and trichoscopy which is largely uninformative. So how does the SARS-CoV-2 virus get into the hair follicle in the first place? Well, the authors remind us in this study that keratinocytes in the outer root sheath express ACE2 and TMPRSS2 just like lung tissue, just like other tissues, and the SARS-CoV-2 virus might get into the skin by binding ACE2 on keratinocytes and then can replicate in hair follicles and skin cells. I think this is a really important study. We have come to learn over the last 3 years that the SARS-CoV-2 virus can not only infect lung tissue, but can infect hair follicles, kidney tissue, brain tissue, heart tissue, and an array of different tissues in the body. And we know that the SARS-CoV-2 can actually reverse transcribe parts of its genetic structure into human genetic material as well. And so it is possible that some of this material persists in the skin and the hair for long periods of time. We're just coming to learn what happens when a person gets infected in terms of hair shedding, development of telogen effluvium, anagen effluvium, alopecia areata. If there truly are viral particles or pieces of viral genetic material left behind in the skin or hair, what are the implications for the skin and hair over 5, 10, 15, 20, 40 years? We don't know. More research is clearly needed, but this is a very important study which highlights that the SARS-CoV-2 virus is finding its way into hair follicles, finding its way into the skin. And this will undoubtedly fuel further studies in this important area. So we move now from hair shedding to 4 very nice studies in the area of scarring alopecia. And then we move to our final 2 studies for the top 20 year. So scarring alopecia are these group of hair conditions whereby the body is forming scar tissue. And that scar tissue destroys hair follicle stem cells, and that scar tissue leads to permanent hair loss. We'll be talking about lichen planopilaris and frontal fibrosing alopecia and central centrifugal cicatricial alopecia today. These are 3 types of scarring alopecias which are commonly seen by hair loss specialists. We'll begin by frontal fibrosing alopecia. Frontal fibrosing alopecia is a scarring alopecia that affects females and males, affects females slightly more than males. But there is an increase in both groups. We're seeing more males come into clinic with FFA. We're seeing more females come into clinic with FFA. The condition was first described in 1994, and since that time, there's been a dramatic increase in reports of FFA, and it's thought to be that it's increasing, and the exact cause is unknown. FFA is a condition which causes hair loss along the frontal scalp, around the back, so it's not truly frontal. It causes eyebrow and eyelash loss, body hair loss. It causes facial papules or bumps. It causes an increased risk for rosacea, changes in hormonal levels, including low androgen levels in some women, may increase the risk for early menopause, may increase the risk for other autoimmune conditions like psoriasis, lichen sclerosis, etc. So a condition which is receiving a lot of attention in the research community to understand the factors associated with FFA, what causes it in the first place, and how to treat it better. But a very, very important study was published in the Journal of the American Academy of Dermatology in March by Dubin and colleagues from New York, titled Scalp and Serum Profiling of Frontal Fibrosing Alopecia Reveals Scalp, Immune, and Fibrosis Dysregulation with no systemic involvement. So let's take a look at this very nice study, a study which suggests that FFA is a skin-predominant inflammatory condition with very limited inflammation in the bloodstream. And it differs in that regard from alopecia areata and psoriasis and atopic dermatitis. So let's look at Dubin's very nice study. So the authors assessed 33,000 genes in the scalp using RNA sequencing and 350 proteins in the serum using high-throughput proteomics. There was 38 patients in their study, 12 with FFA, 18 with alopecia areata, 8 controls, and biopsies were taken from all patients. These were 4.5 millimeter little punches. And so the authors found there was 1,218 genes which were differentially expressed in the scalp of FFA compared to alopecia areata. And so very different genetic expression in these 2 conditions. The most significantly altered markers in FFA included those related to inflammation, Th1 signaling, T cell activation, fibrosis, T regulatory cells, and the JAK-STAT pathway, or the Janus kinase pathway. What was so interesting is that activation of the JAK-STAT pathway, or the Janus kinase pathway, seemed to correlate well with fibrosis. In other words, if there was a little bit of JAK-STAT pathway activation, there was a little bit of fibrosis activation, or the pathways leading to scarring. If there was a lot of JAK-STAT activation, there was a lot of activation of pathways associated with fibrosis, suggesting that this JAK pathway is very related to the development of fibrosis, which is important to researchers because we have JAK inhibitors available to treat the condition. But what was so interesting is there was more robust inflammation in the scalp in FFA compared to alopecia areata. There was just one upregulated protein in the serum of FFA that differed from controls, and that was this ADM, or apoptosis-related gene, ADM. And ADM has many functions, including vasodilation, regulation of hormone secretion, angiogenesis, and antimicrobial activity. So it has a number of roles which are poorly understood, but just one protein was different in the serum compared to controls. And that differed from alopecia areata, where there was significant inflammation in the serum. 73 proteins in alopecia areata, 45 in atopic dermatitis, 47 in psoriasis. So evidence here of significant inflammation in the body in alopecia areata, atopic dermatitis, psoriasis, these autoimmune diseases, but not in FFA. So in FFA, there was more scalp inflammation, very little systemic serum inflammation. In alopecia areata, there was a lot of inflammation in the serum, very little scalp inflammation, comparatively. So the authors propose that FFA is a condition for which robust inflammation is limited to the scalp, and it may be a very different inflammatory condition compared to alopecia areata, atopic dermatitis, and psoriasis. And they show that fibrosis is very much a part of the pathogenesis of FFA, and it seems that the JAK-STAT pathway is driving fibrosis, or at least seems to be. And so there's many unknowns here. The conclusion here, and the authors put it in their title, is that FFA seems to be a scalp-predominant inflammatory disease, so a lot what's going on in the disease is limited to the scalp. There's a lot of questions that are unanswered and remain, and most good studies really open the door to a lot of questions, and that's what good studies do. And so one question is, are patients with FFA truly at increased risk for some of these systemic diseases? If FFA is a scalp-predominant disease, and we should be focusing on scalp, then what does all this other information mean? We know that patients with FFA we know that patients with lichen planopilaris are at increased risk for heart disease. We know that from the CONIC study. If FFA is thought to be a close cousin of LPP, then are patients with FFA at increased risk for heart disease? Is FFA a condition whereby heart disease isn't at increased risk? Maybe it's completely different from classic lichen planopilaris. We don't know. Do we accept this concept that FFA is a scalp-only disease? We know that eyebrows, eyelashes can be affected, body hair can be affected. What's happening there? Is it the same pathways? Is it the same upregulation of JAK-STAT signaling, Th1 signaling, differences in other pathways that are identical to what's going on in the scalp, or is it different? And so what's happening in those specific situations? And are the systemic associations that we see in FFA relevant? What do we make of the early menopause that's thought to occur in FFA? Sergio Vagno's study in 2014 suggested that 14% of women with FFA have early menopause compared to 1% in the general population. It's thought that there's an increased risk of lichen sclerosis, genital lichen sclerosis, psoriasis, low androgens. What do we make of these associations? There's a twofold increased risk of rosacea in women with FFA. How do we tie that in to this study, which suggests that FFA is a scalp-predominant disease? We know that medications like tamoxifen can trigger FFA. 15-fold increased risk of FFA in tamoxifen users. Other drugs like ustekinumab for psoriasis can trigger FFA, rarely. But if systemic drugs can trigger FFA, then how do we tie in that conclusion that FFA isn't a systemic disease? So a really fascinating study, which opens the door to a lot of great questions. And we talked about the increased risk of early menopause. And there's a lot of autoimmune diseases in FFA, psoriasis, thyroid disease, lichen sclerosis, lichen planopilaris, of course, discoid lupus. So lots of autoimmune diseases are increased in FFA. How do we tie this into an understanding that FFA in the serum and 350 proteins analyzed has very little of those suggestions of inflammation? So more studies are needed. Fascinating condition. We desperately need additional treatments and additional understanding of what causes this disease. And it very well may be that there is not one form of FFA, that there's many forms of FFA, and we're grouping them together at the present time, and they have the same clinical presentation, but they may have differences that we need to sort out, and that could explain some of this. But we have a long way to go to understand FFA. We move now to CCCA, central centrifugal cicatricial alopecia, a scarring alopecia in Black women, which is not uncommon. Up to 18% of Black women have CCCA. It's underdiagnosed, underreported. It's dramatically more common than we realize. A very nice study by Jamerson and colleagues changes our views on CCCA. A really important study to know about, and I'd like to explain it to you, because it changes the counseling that goes on in the clinic, and it changes the way we think about CCCA. The title, Gene Expression Profiling, suggests severe, extensive CCCA may be both clinically and biologically distinct from limited disease subtypes. So when a patient comes in with early CCCA, just a little bit of hair loss centrally in the middle of the scalp, we often think, I'm glad you came in early. We're catching this early. There's lots that we can do. Steroid injections, topical steroids, topical calcineurin inhibitors, doxycycline, sarecycline. And when a patient comes in late, our feeling is we have limited ability to get hair back. It would have been great if you had have come in earlier. Of course, we may not say that to patients. Sometimes they may even say it to us. Do you think if I came earlier, doc, it would have been better? And sometimes we feel maybe it would have. The study by Jamerson changes that. It changes that kind of thinking, and I'd like to review that with you. So Jamerson analyzed 16 patients, performing punch biopsies in those patients, and they performed RNA isolation and microarray analysis, and they showed that there were 12 genes that were upregulated in CCCA. They compared the genes in extensive CCCA, so patients with more advanced hair loss, compared to focal limited CCCA. And they showed that several genes were upregulated in advanced CCCA compared to early focal CCCA. And patients with more advanced disease were more likely to have expression of MMP9 or matrix metalloproteinase 9, SRFP4 or secreted fissile-related protein, macrophage scavenger receptor 1, MSR1, lysozyme, and NCK-associated protein like 1. And the authors propose here that extensive CCCA may be clinically and biologically distinct from mild CCCA. So it's not simply that extensive CCCA is on a spectrum of mild CCA, that you start out with mild CCCA. If it's not treated, it goes on to moderate CCCA. And if it's not treated, it goes on to severe CCCA. Yes, that might occur. It probably does occur. But the information here suggests that extensive CCCA is a unique entity to itself, that possibly there are genes that are driving the development of a more aggressive form of CCCA. And so, whereas we used to say in early CCCA, we're catching it early, this is good. In advanced CCCA, we think patient should have come earlier. We're changing that type of thinking now. In early CCCA, the suggestion is that you may have a mild form of CCCA because you have a distinct gene expression profile that keeps it mild. And in advanced CCCA, maybe some of the patients have a form that should have been treated earlier and it has progressed. But a significant number of patients probably have a distinct gene expression profile which is driving the development of a more aggressive form of CCCA. And so it's not necessarily that you should have come earlier. It is that you may have a distinct gene profile which is creating an aggressive form. And perhaps in the future, if we understand the genes better, we can predict what type of CCCA a patient will have and will be better able to tailor therapies. And since the publication of this study, many patients have asked me, can you test my genes? Can you test me for lysozyme? Can you test me for MSR1s, secreted frizzle-related protein 4? Well, the answer is not yet. But that day is coming where we understand more about a person's genetic profile and towards more personalized type medicine where we understand what to do with this information. But we don't yet have that ability yet, nor do we confidently know how to structure that information. But it certainly could be that if a patient comes into clinic and we identify that they have a certain gene profile that predicts an aggressive disease, then we might say to them, I think you should start topical calcineurin inhibitors, topical steroids, steroid injections, a systemic therapy like doxycycline or sarecycline. I think that's the route we need to go right away because your genetic profile is predicting a more extensive disease. And so those days are coming when we come to understand how to use genetic information more. But the Jamerson study is so important because it changes our thinking about CCCA. So we move now to lichen planopilaris. Lichen planopilaris is a scarring alopecia that affects both women and men. Women probably slightly more than men. It affects patients in their 30s, 40s, 50s, 60s. Patients often have hair loss in the central scalp, but it could be all over. They have itching and burning and pain, but not all do. But itching, burning, and pain are common, as is increased shedding. So Joshi and colleagues set out to determine the prevalence of lichen planopilaris using a research database called the All of Us database, a relatively new research database. And so how common is LPP, lichen planopilaris? Well, that's indeed the question of Joshi and colleagues. So authors from Baylor set out to determine the prevalence using this cohort study database called the All of Us database. They use the ICD code L66.1 as well as the SNOMED code 645400004 to identify LPP patients in that database. And this includes patients with lichen planopilaris and FFA who have the same code. And so the All of Us database, as of March 2022, when these authors performed the study, had about 327,000 participants. There was 142 patients in that database with LPP, representing a prevalence of about 1 in 2,325. And so the authors estimate that the prevalence of LPP is about 1 in 2,000. The average age at diagnosis in this study was 62 years. Females comprised most of the patients with LPP. But what was so interesting in this study, in addition to the calculation of prevalence, was the prevalence according to age group. And they proposed that in those 65 to 74, the prevalence may be as high as 1 in 1,000. In those 55 to 64, it may be 1 in 1,800, 1 in 1,800. It may be higher in white individuals, 1 in 1,750. In black individuals, 1 in 3,500. Hispanic, 1 in 5,000. And in Asian, 1 in 11,000. So it's a really nice study. We don't have a lot of good data about the prevalence of lichen planopilaris. These studies are hard to do. They make a lot of assumptions. They often have a low number of patients. And there are limitations with all these prevalence studies. One of the limitations of this study is it doesn't separate lichen planopilaris from FFA. FFA is thought to be a type of lichen planopilaris, so it has the same coding at the present time. But it gives us some idea about the prevalence of lichen planopilaris, and I really like this study. Trager and colleagues in 2021 published a study. This is a group from New York. They published a very nice study suggesting that about 1 in 6,000 patients in their database from New York have lichen planopilaris. And when I read that study in 2021, my immediate feeling was, I think LPP is more common than that. We don't yet have the tools and resources to really confidently identify the true prevalence, but I think there's more than 1 in 6,000 people out there walking around have lichen planopilaris. And so when Joshi and colleagues published their study this year, my feeling was, this is really interesting. I think we're getting closer to the true number. Who knows what the number truly is? It might be different in the United States than in parts of Europe. It might be different in parts of Europe than in parts of Asia. It might be different in parts of Asia than in Australia. That is quite likely that it differs, but nevertheless, lichen planopilaris in North America at least is probably more common than 1 in 6,000. And so having this JOSHI data suggesting maybe 1 in 2,000, maybe as high as 1 in 1,000 in those 65 to 74, I think is really helpful and will fuel additional studies to really identify the prevalence. JOSHI and colleagues used the same database to perform a study looking at comorbidities associated with lichen planopilaris. And this study really builds upon some very nice data by Koenig and colleagues. Koenig and colleagues published a very nice study in the Journal of the European Academy of Dermatology and Venereology in 2021 looking at some of these associations with LPP. Let me remind you about Koenig's study and then we'll dive into JOSHI's study. So Koenig and colleagues performed a study comparing 3,170 patients with lichen planopilaris to 63 million controls. They found in patients with lichen planopilaris, there's an increased risk of hyperlipidemia, high blood pressure, obesity, diabetes, a 10-fold increased risk of metabolic syndrome in LPP compared to controls, an increased risk of coronary artery disease, atrial fibrillation, heart attacks. And so JOSHI performed a study this year trying to further identify some of these associations. What type of association should we be aware of in LPP? So they again used this All of Us database, this new database, to identify patients with LPP in that database. And that includes LPP and FFA. But what they found is that in patients with LPP coding, there was an increased risk of psoriasis, atopic dermatitis, melanoma, basal cell cancer, rosacea, squamous cell carcinoma, inflammatory bowel disease, rheumatoid arthritis, lupus, ischemic heart disease, insomnia, hyperlipidemia, hypothyroidism, high blood pressure, anxiety, and depression. And these were all statistically significant compared to controls. So I think this is really important information. It really draws attention to these associations and builds upon the Koenig study of 2021 in the JEADV. Again, I think these associations are so important. We are a field of hair loss medicine, and that can't be forgotten, that we are not only focused on studying hair follicles and how they grow and don't grow, but these associations are so important to our field and understanding the relevance of this information. Patients with androgenetic hair loss are at increased risk for metabolic syndrome. Patients with alopecia areata are at increased risk for metabolic syndrome. Here, patients with lichen planopilaris at increased risk for metabolic syndrome of tenfold, as well as psoriasis, atopic dermatitis, autoimmune disease, depression, anxiety, insomnia. This is really important information. I think this will definitely fuel additional studies as we come to understand these important associations. The reason these are so important is clearly when we see someone with scarring alopecia, we have to be thinking about these associations. When you see someone with lichen planopilaris, should we be asking about, have you had a skin check for squamous cell, basal cell melanoma? Is there a history of melanoma in your family? Do you have high blood pressure, hypertension? Do you have diabetes? Do you have high blood sugars? Do you have joint pain? How's your sleep? We should be asking about all these associations. Right now, it seems a little bit far-fetched to go into a detailed history of melanoma family history and personal history of skin cancers in a patient with lichen planopilaris who wants you to stop their scalp itching. But this study reminds us it's relevant. And how do the treatments that we administer affect these associations? If we administer a certain immunosuppressant, to a patient with lichen planopilaris, are we altering their risk for melanoma, squamous cell, basal cell? If there's an increased risk for coronary artery disease and heart disease in lichen planopilaris, do the treatments that we administer alter that risk in any way? Do they increase the risk? Do they provide preventive and protective effects on heart disease? That's why it's so important. We are not working on hair follicles in isolation. We are working on helping hair growth and stopping hair loss in association with all these other parts of the body, and we need to understand them well. And I think this Joshi study is really important and ties in with the conic study and really reminds us that we are an evolving field of hair loss medicine. Our final two studies, we move now to Chang and colleagues, a study published in the Journal of the National Cancer Institute, 2022, looking at the risk of uterine cancer in patients using hair straightening products. So a new study concludes that hair straighteners increase the risk slightly of uterine cancer, and women who use hair straightening products more often, chemical straighteners, have an increased risk of uterine cancer even greater than those who use them less frequently. So it's been previously suggested that use of certain products can be associated with an increased risk of cancer, and it's thought that cancer might come about because of the chemicals that we use in our day-to-day and their ability to act as what's called endocrine disruptors. And previous studies have suggested that some hair products may increase the risk of ovarian cancer, breast cancer, and that includes hair straighteners. And these authors had performed those studies in the past, suggesting that hair straightening chemicals may increase the risk of those cancers, and here they show that it increases the risk of uterine cancer. So the authors examined the association between hair straightening products as well as other products and the risk of uterine cancer in 33,000 participants aged 35 to 74. Patients completed a questionnaire. They provided a whole bunch of data on products they use, including hair dyes, hair straighteners, relaxers, pressing products, permanent waves. 378 uterine cancers were identified in this study, which followed patients for an average of 11 years of follow-up. But patients who used hair straightening products in the last 12 months had a 1.8-fold increased risk of uterine cancer. And patients that used hair straightening products even more frequently, 4 or greater than 4 uses of hair straightening products, chemical straightening products in the last 12 months, had a 2.5-fold increased risk of uterine cancer. The use of other products like dyes, permanents, body waves was not associated with uterine cancer in this study. And so these studies provide some of the first epidemiologic evidence suggesting that hair straightening products are associated with an increased risk of uterine cancer. This is a well-conducted study, large study, using a racially and ethnically diverse population. And it's known that exposure to excess estrogen and this imbalance between estrogen and progesterone is a risk factor for uterine cancer. For example, it's well known that when estrogen is given to women who have a uterus and haven't had a hysterectomy, that progesterone must be given at the same time, because if estrogen is just given alone, it increases the risk for uterine cancer and endometrial cancer. And so it is proposed that some of these chemicals that are used may act as endocrine disruptors and trigger estrogen-type signaling, and that may be one of the mechanisms by which some of these cancers develop. And so some of these hair products and hair straightening chemicals are thought to be associated with development of cancer. And here, breast and ovarian cancer had prior studies suggesting an association, and here we have evidence of an increased risk of uterine cancer. We don't know the ingredients that are responsible for the development of uterine cancer or breast or ovarian cancer. That study was not collected in this particular study. It is a source of ongoing research, but this was a survey-based study trying to assess how often patients use these chemicals and what they use and their ultimate development of cancer. But I think this is really important data, and I think that many of the products we use in our day-to-day are affecting our risk for certain negative health impacts. And this data is really important because it's up to us to understand this information to advise patients that are at increased risk. But of course, this data is so important to our regulatory bodies to make sense of what to do with this information and what warnings to place on labels, what products to limit in the market, what products to ban in the market. And these are tough questions, but I think this is very solid epidemiologic information, which ties in a relationship between chemical hair straightening products and the development of several hormonal-dependent cancers, and further studies and further information is needed to really understand the groups that are at the highest risk and what to do with this information to help limit the development of cancer in individuals using these products. So we move now to our final study, Study 20, a study looking at the risk of osteoporosis in patients with seborrheic dermatitis, a very unique study published in the Japanese literature, the Journal of Dermatology. It's a study from Taiwan titled Impact of Seborrheic Dermatitis on Osteoporosis Risk, a population-based cohort study. So osteoporosis is a systemic bone resorbing disease that causes bone fragility, increases the risk for fractures, and the risk of osteoporosis increases with age. And overall, about 23% of females will experience osteoporosis, and that's 11% of males. And osteoporosis is a very important medical condition in our population. The risk factors for osteoporosis are divided into two categories: the modifiable risk factors and the non-modifiable risk factors. The modifiable risk factors are those that we can change. Low body weight is a risk factor. Smoking, alcohol, lack of exercise, lack of dietary calcium, long-term use of prednisone, these are modifiable factors. The non-modifiable factors are the things we can't do much about. Age, gender, race, genetics. Those are the non-modifiable risk factors for osteoporosis. Now, what is seborrheic dermatitis? And then we'll get into this very nice study suggesting that seborrheic dermatitis may be associated with an increased risk for osteoporosis. Well, seborrheic dermatitis is an inflammatory skin condition. It can affect the scalp and is very much thought to be a close cousin of dandruff. It can affect the area around the nose. It can affect the chest. It can affect any oil-rich area of the skin. About 5% of the world has seborrheic dermatitis. It's thought that Malassezia yeast play a very important role in the development of seborrheic dermatitis, but there are other very important factors as well, including changes in the microbiome, certain environmental factors, but there's many risk factors. But seborrheic dermatitis occurs on the seborrheic areas of the body: the anterior chest, the axilla, the groin, the back, the central area of the face, the area around the nose, the scalp. These are all oil-rich areas. And the incidence of seborrheic dermatitis is highest in infants and adolescents, and then again in those 30 to 60 years of age. There are risk factors like neurologic disease, stress, being male, HIV, weather, cold weather, depression, poor sleep, humidity, Western diets, alcohol, race, high altitude, medications, lymphoproliferative disease, immunosuppression. These all increase the risk for seborrheic dermatitis. The one thing which has not been clear is whether patients with seborrheic dermatitis have an increased risk for osteoporosis, and the authors became interested in these associations because of the fact that seborrheic dermatitis is an inflammatory condition, and they wondered whether the inflammatory signaling and the inflammatory type pathways could be associated with the same pathways that increase the risk of osteoporosis. So they used the Taiwan National Health Insurance Research Database, this large database, to look at individuals diagnosed with seborrheic dermatitis and individuals diagnosed with osteoporosis to ask the question, do patients diagnosed with seborrheic dermatitis have an increased risk of being diagnosed with osteoporosis? And so they compared the risk of osteoporosis in patients with seborrheic dermatitis compared to the risk of osteoporosis in patients without seborrheic dermatitis. So the study group included 7,831 patients aged 18 to 50 with seborrheic dermatitis, and the control group included 31,324 patients without seborrheic dermatitis, and patients were matched by age, gender, and comorbidities. And overall, about 1% of patients with seborrheic dermatitis had osteoporosis, compared to about 0.66% in the non-seborrheic dermatitis group. But when patients were adjusted and matched for various variables known to influence the risk, compared to patients without seborrheic dermatitis, patients with seborrheic dermatitis had a 6-fold increased risk of osteoporosis. The impact of seborrheic dermatitis on the risk of osteoporosis was highest in female patients, and what was particularly interesting is it was highest in younger age groups as well. Not a lot of young patients, 18 to 29, have osteoporosis. But in this study, if you had seborrheic dermatitis, the risk of osteoporosis in that young age group was increased about 7-fold. Similarly, in the 30 to 39-year-old group, not a lot of patients have osteoporosis, but if you had seborrheic dermatitis, your risk of osteoporosis was increased almost 10-fold. And in the 40 to 49 group, it was 7.31-fold. And so osteoporosis risk increased with age, but there was significantly increased risk that was going on in younger patients with seborrheic dermatitis, where we don't tend to see osteoporosis all that often, but if you had seborrheic dermatitis, you had this increased risk of osteoporosis. Patients with seborrheic dermatitis tended to develop osteoporosis more rapidly, 2.2 years after enrollment in the seborrheic dermatitis group compared to 9 years in the control group. So this was one of the first studies to demonstrate that seborrheic dermatitis is associated with osteoporosis. And if you had seborrheic dermatitis and hyperlipidemia, hyperthyroidism, or epilepsy, you were at particularly increased risk of osteoporosis. And it was particularly interesting that this risk of osteoporosis is affecting some of the younger patients as well, affecting individuals in their 20s and 30s, age groups where one doesn't typically think about osteoporosis risk. So a really nice study highlighting this association and will certainly fuel additional studies. Does this apply to scalp seborrheic dermatitis? In this particular Taiwanese research database, patients with seborrheic dermatitis of the skin, of the nose, of the back, of the chest, of the scalp were coded in the same way. Does this information apply to seborrheic dermatitis of the scalp? We don't know. Does mild seborrheic dermatitis have the same risk as severe seborrheic dermatitis? We don't know. We code things the same in these databases. So if someone comes into clinic with severe seborrheic dermatitis, and we learn by history that their mother or sister have osteoporosis, does the fact that the patient has severe seborrheic dermatitis change our thinking in any way compared to if they came into clinic with mild seborrheic dermatitis? We don't know. What do we do with this information? If a patient comes into clinic with seborrheic dermatitis and they're 45 or 50, should we be asking about fractures, osteoporosis, family history? Should we be moving up the age at which bone mineral density testing is done? We don't know. These are all important questions for the future. And good studies fuel good questions like this, and we really need more research. And of course, can we modify the risk? Can we change a person's risk of developing osteoporosis by using this information in some way? Are there certain features of seborrheic dermatitis that will allow us to have someone undergo a bone mineral density test at an earlier age than they otherwise would? And can we get that patient started on certain treatments or certain lifestyle protocols which can alter their risk for developing osteoporosis in the future? We don't know. These are important questions. But I really like this study highlighting this association that we really hadn't appreciated in this same manner before. I'd like to thank you so much for joining me this evening. These are the top 20 studies of 2022. These are studies that have changed the type of thinking that goes on in the clinic. These are the studies that change the type of counseling we give to patients, the way we prescribe medications, the way we diagnose hair loss conditions. And I think these studies have really helped me a great deal, and I hope you found them interesting, and I hope these studies will be helpful to you in your practice if you're a practitioner joining me this evening. If you're a patient or a family member, I hope you've enjoyed these studies, and I hope you found them helpful in some way. We will now open the webinar to questions, and I welcome your questions. Please do enter them in the chat box. But I do want to thank you so much for joining me this evening. I really appreciate all of the wonderful comments and feedback that we've received, and I look forward to reviewing again with you some important studies which change the landscape of the hair loss medicine community. Thanks again.